Thank you for the introduction. Thank you, Brian. I'm going to try to move quickly to try to catch up so that we can leave at a reasonable time here. So I'm going to cover gynecological malignancies, and as you know, there are no approved drugs except pembrolizumab was approved for mismatch repair just recently within the last 4 weeks. And as you will know, most of the patients are really in endometrial cancers, particularly in females. Most of my talk will cover checkpoint inhibitors. There are other immunotherapies too, monoclonal antibodies, immunoconjugates, therapeutic vaccines, and adoptive T-cell therapies and viruses that we would just cover briefly. I'll present cases from my practice. The first case is a 50-year-old female who had endometrial cancer. She presented in May 2015 with postmenopausal bleeding, had a grade 3 endometrioid tumor, had surgery for it. Unfortunately, the tumor was very advanced, had positive periodic nodes, deep myometrial invasion. The patient had analysis for mismatch repair by immunohistochemistry, and her tumor lacked MSH2, MSH6. She had a PE and DVT, and even before the chemo was able to be started, she had evidence of progressive disease, a very aggressive tumor. She developed severe bleeding leading to radiation palliatively in order to stop the bleeding, and then she got started with chemo, and just as the chemo was completed, she had evidence of progressive disease. Unfortunately, very aggressive tumor. We had to switch her treatment to gemcitabine and paclitaxel, to which she initially responded, but then she quickly progressed and developed anasarca, developed progressive supraclavicular adenopathy and worsening pain. We were about to send her to hospice. This is actually before pembrolizumab was approved, but we started her in nivolumab, and she obtained a remarkable response. Within 2 or 3 weeks, all her anasarca had resolved, all her adenopathy had resolved. Here is a picture of her supraclavicular adenopathy on the right that had almost completely resolved on the left. Up to a third of the patients with endometrial cancer will have mismatch repair deficiency, either inherited or acquired. It is the most common presentation for Lynch syndrome, endometrial cancer in females, even more common than colorectal cancer. Up to 40% of the female patients will develop endometrial cancer, female patients with Lynch syndrome. As I mentioned, pembrolizumab was just approved for mismatch repair tumors, not just colorectal, but also non-colorectal tumor. This is the most recent publication summarizing the data from Science just a month ago. This approval was based on 5 different phase 2 trials that involved 90 colorectal cancer patients and 59 non-colorectal cancer patients. As you can see from this here, the response rates are quite significant, about 60% and up to 30% complete remissions, and they are quite durable, as you can see in the figures, in the lower figures down there. Mismatch repair deficiency can be seen in a lot of different tumors. This is a series of 12,000 tumors. And as you can see, the prevalence varies quite significantly. The first bar that you can see there is endometrial cancer, where the prevalence can be as high as 20%, but they can be seen as an acquired deficiency in any of the gynecological tumors and many of the other tumors that are listed there, as you can see. Now, moving on to ovarian cancer, we would have thought that perhaps ovarian cancer would be a tumor where immunotherapy would be approved early. And this is because back in 2003, there was a very important article published in the New England Journal of Medicine that showed that tumors that had an increased number of T cells infiltrating the tumor had a much better prognosis, and that the presence of infiltrating T cells in the tumor actually was even better at predicting outcomes than even whether the patient had adequate debulking or not. Probably the reason why these agents are not as active in ovarian cancer, maybe as Dr. Hamid was mentioning, there are a whole bunch of other checkpoint proteins that are involved in immunosuppression, and probably we're not hitting the right inhibitor. Nivolumab was studied and reported in 2014 and eventually published in 2015 by the Japanese group, and it showed about 18% response rate. In 2015, there was a report on avelumab in ovarian cancer where the response rate was 10%, and that's summarized in this slide. And there were 2 cases actually of clear cell carcinoma that had excellent response, 2 out of 2. Clear cell carcinomas of the ovaries are rare tumors. Molecularly, they resemble renal cell carcinoma, so maybe the response rates to these agents is higher in these tumors. This is one of the patients who had clear cell carcinoma that responded to avelumab pre-treatment on the left and post-treatment on the right. This is a case of mine with clear cell carcinoma that had a great response to nivolumab, which is still ongoing after failing multiple chemotherapy in the past. This is actually some of the pictures of my patient with the significant adenopathy noted in this area with significant response following nivolumab therapy. This year we had a report on pembrolizumab on PD-L1 positive ovarian cancer in the ASCO meeting. And as you can see, there was significant increase in responses by selecting the patients for PD-L1 positivity, with a 26.9% of the patients having the decrease in the tumor size in this phase 2 trial that was reported in ASCO. The responses were also durable in these 3 patients who had a significant response, which is lasting over 2 years. Ongoing studies, there are a quite significant number of them, including a very large neoadjuvant and adjuvant trial, including paclitaxel, carboplatin, and bevacizumab plus minus atezolizumab. This study actually is going to involve 1,500 patients and is about to be activated or activated at this time. There's other, this is also a list of other trials combining chemotherapy with the checkpoint inhibitors that are either ongoing at this time, and we look forward to these reports. There are also ongoing studies of the combination immunotherapy in ovarian cancer that I have listed. Now, as far as monoclonal antibodies, we know that bevacizumab is approved in the relapse setting. Just this year, it was approved in the platinum-sensitive relapse setting together with chemotherapy. Previously had been approved in the platinum-resistant state. Under study are a series of monoclonal antibodies and immunoconjugates directed against the folic acid receptor and against the sodium phosphate channel and other proteins, demonstrating some activity already in phase 2 trials. There's also studies looking at different vaccines against different proteins, including P53 and NY-ESO1. There are also studies involving adoptive T-cell transfer in ovarian cancer. At the Mayo Clinic, we do have a trial, a randomized phase 2 trial looking at a modified measles virus administered intraperitoneally versus chemotherapy in the platinum-resistant patients. Moving on to cervical and vaginal cancer, you would think that this is also another subset that would have significant activity based on the Merkel cell activity and based on the fact that it is a virally induced tumor. This is one of my patients, a 77-year-old female who has HPV-related vaginal cancer, treated initially with radiation and chemotherapy in 2014, and who relapsed in November 2015, for which she was recommended to have exenteration, and she said, no way, I'm not going to have exenteration. She was not interested in chemotherapy, and we were able to secure nivolumab for her, which has been associated with significant regression of her tumor, which is ongoing now 18 months later. Back in 2015, there was this report from the NCI using tumor-infiltrating lymphocytes which had been exposed in vitro to the HPV viral proteins and then expanded in vitro, and then the patient received cyclophosphamide fludarabine followed by the infusion of these T cells. And in this report published in JCO in 2015 of 9 patients, there were 4 of the 9 patients obtained responses, including 2 complete remissions. This study is still going at NCI. These are some pictures of some of the responses. Last year at ASCO, there was a report on the pembrolizumab, the use of pembrolizumab in cervical cancer, the KEYNOTE-28 study. And in this report, there was significant activity with 38% of the patients having significant regression. In the SGO meeting this spring, there was a report of these, this is on the ASCO meeting this year, a report of nivolumab in cervical, vulvar, and vaginal cancers with excellent responses, particularly in the cervical cancer patients, and the responses are ongoing in some patients with a median progression-free survival of 5.5 months and a 6 months overall survival of 87%. In SGO, there was a report of these Listeria modified bacteria, which is modified to not be very pathogenic and is modified to express the E7 protein of the HPV virus. This GOG trial, which was a phase 2 trial of 50 patients, demonstrated a 12 months overall survival of 38%, which exceeds that the survival that had been seen at 12 months in all previous GOG trials of cervical cancer, relapsed cervical cancer, which none of them had any overall survival greater than 30%. The one that had the greatest response was actually bevacizumab, which later on became approved with cervical cancer. This bacteria is modified not to cause significant problems and to express the E7 protein of HPV, is picked up by the dendritic cells, which leads to T4 and T8 activation, which the hope is that this then leads to tumor regression, which were seen in this trial reported in SGO, with, as I mentioned, the 12 months overall survival of 38%, including one patient who had a complete remission that is lasting now for over 2 years. Currently, there is a proposal of studying this bacteria infusion in patients at high risk of cervical cancer following definitive therapy with chemoradiation and compared with placebo in a phase 3 trial. And there is an active trial combining this agent with the MEDI anti-PD-L1 agent versus the MEDI agent by itself in a trial that is open at many centers, including our center here at Mayo in Jacksonville and at the University of Miami. Moving on to breast cancer, as you know, we do have monoclonal antibodies against HER2, which probably act via immune mechanisms, including pertuzumab and trastuzumab. There is significant activity of checkpoint inhibitors against triple-negative breast cancer, and we're going to talk about that a little bit. And there's the TDM1 agent as an immunoconjugate that is approved for HER2-positive disease. And there are multiple studies involving adoptive T-cell therapy and vaccinations. This is one of my patients with metastatic breast cancer, HER2-positive, presented in October 2012 with multiple tumors in the left breast, ranging in size from 8 millimeters to 38 millimeters, with 28 positive nodes, including an infraclavicular node. She had a BRCA1 germline mutation, and she was treated adjuvantly with TCH, followed by radiation, followed by trastuzumab and letrozole, because her tumor was also ER positive. She relapsed several years later with right hilar adenopathy and lung nodules and liver metastases. The tumor this time was ER negative, but HER2 positive again. And this time we treated her with docetaxel, pertuzumab, and trastuzumab for 6 doses with a complete remission, followed by pertuzumab and trastuzumab. This is her PET scan before and after, showing the complete remission. And as you are all familiar, the Cleopatra trial showed the great advantage of adding pertuzumab in the metastatic setting to trastuzumab in patients with HER2 positive metastatic breast cancer, which was associated with a significant prolongation of progression-free survival and overall survival. This year in Lancet Oncology, there was an analysis of the Cleopatra data, which demonstrated that the tumors that had increased number of T cells also, and that had received pertuzumab, there was an additional beneficial effect from the pertuzumab in the tumors with T-cell infiltration, suggesting that maybe there is an additional beneficial effect from combination treatments with these anti-HER2 agents and checkpoint inhibitors in the future. This is another patient of mine with 70-year-old with metastatic breast cancer at presentation with bone, liver, and lung metastases, which was started on docetaxel, pertuzumab, and trastuzumab, but she had significant side effects, and we switched her to T-DM1 in July 2013. She has now completed actually about 60 cycles of treatment, and she has ongoing dramatic responses with minimal toxicity, which reflects the great responses that we can see with this immunoconjugate T-DM1, which was proven in the Emilia study several years ago, showing a benefit in terms of progression-free survival and overall survival compared to capecitabine and lapatinib. So finally, talking about triple-negative breast cancer, this is one of my patients, young patient, who presented with a huge tumor, triple-negative breast cancer tumor, and this was after initial chemotherapy. Unfortunately, this is not what we see most commonly. And obviously, a lot of the triple-negative breast cancers are many different tumors, as you all know. This is the data on checkpoint inhibitors on triple-negative breast cancer, which had shown response rates varying from 19% to 10%. And some of the responses, as shown in this curve, are long-lasting. In San Antonio breast cancer meeting of 2016, there was an update of the keynote study on triple-negative breast cancer with median follow-up of 10.7 months and 32 patients with a median progression-free survival of only 1.9 months, but a 12 months progression-free survival of 17% and a median overall survival of 11.3 months with 33% response rate noted. These has led to trials of combining chemotherapy with some of these checkpoint inhibitors, and those studies are ongoing. In the ASCO meeting this year, we heard about the I-SPY2 trial. This is a neoadjuvant trial, and one of the arms included the addition of pembrolizumab combined with paclitaxel in a combination followed by AC neoadjuvantly. So some patients received that, some patients received just paclitaxel. And what was observed was a dramatic increase in pathological CR by the addition of pembrolizumab, from 20% in the group that didn't receive the pembrolizumab to 60%. So there's then a proposal to do a randomized study of pembrolizumab in the neoadjuvant study. It's very interesting because maybe pembrolizumab, maybe these agents work best in the neoadjuvant setting. Also, they did see a tripling of pathological CRs in the hormone receptor positive group by adding pembrolizumab from 13% to 34%, so those studies will be done as well. Checkpoint inhibitors are also being studied in combination with other targeted agents in breast cancer and also with other immunological agents, as well as there are trials of vaccines and adoptive cell therapy for this disease. So, in summary, so we know now, finally we have an approval for patients with endometrial cancer and other MMR-deficient tumors with pembrolizumab based on a significant response rate and up to 30% complete remission. So you need to check all of your tumors perhaps for this possibility, which could be acquired or inherited. HPV-related cervical and vaginal cancers are showing response rates of up to 30% in phase 2 trials. And there's definitely a subset of ovarian cancer that responds to this agent. And based on the I-SPY2 trial, there's really a lot of hope that perhaps the combination of pembrolizumab with chemotherapy in the neoadjuvant setting may prove to be beneficial to our patients. And there are lots of studies looking at combination treatments for these tumors. And I greatly appreciate your attention and hanging in there this afternoon to listen to us. Here's my cell phone number and my email address, and I'll be glad to talk to you at any time about any of your patients. Thank you very much.